Hi, my name is Annasha Vyas, and I will be presenting on the impact of an outpatient paracentesis clinic on ED utilization at a safety net hospital. As some background, cirrhosis is a complication of advanced liver disease that causes significant morbidity and mortality, which in turn places a large burden on the U.S. healthcare system. One of the most common complications of decompensated cirrhosis is refractory ascites, which is managed in one of two ways, either through a transjugular intrahepatic portosystemic shunt procedure, also known as TIPS, or through performing serial large volume paracenteses. Paracentesis is generally a safe procedure that can be performed in a clinic. At most hospitals, patients are referred to radiology in the outpatient setting to undergo paracentesis. However, at safety net hospitals, this option is not feasible due to the limited resources and large number of patients that the hospitals serve. As such, these patients pose a challenging problem to the healthcare system due to overutilization of ED resources for completion of these non-urgent procedures. The purpose of this study was to create a half-day fluid aspiration or FLASP clinic that is dedicated to performing large volume paracenteses in the outpatient setting in order to decrease overutilization of the ED at LAC-USC Hospital, a large metropolitan safety net hospital. The FLASP clinic was established on February 11, 2021, and it consisted of a physician, a nurse, and a scheduling clerk. Patients were referred into the clinic either by the ED, internal medicine, or gynecology. We conducted a retrospective study of all patients who underwent a paracentesis in the ED from December 2020 to June 2021. We examined all patients based on their age, gender, and whether they were admitted to the hospital versus discharged from the ED after their paracentesis. The number of patients presenting to the ED for a paracentesis were compared pre and post establishment of the FLASP clinic. No significant difference was noted between the two groups in regards to age and gender. The top graph shows the trend of the number of patients presenting to the ED for a paracentesis who were subsequently admitted or discharged. The red line represents patients who underwent a paracentesis and were subsequently discharged from the ED, while the dark blue line represents patients who were admitted after their paracentesis from the ED. The yellow arrow represents the date the FLASP clinic was opened. As you can see, there was a decrease in the number of discharged patients after establishment of the FLASP clinic in February 2021, while the number of admitted patients remained about the same. Specifically, the mean number of patients presenting to the ED pre-establishment of the clinic was 2.18, while the mean number of patients presenting post-establishment of the clinic was 1.17. This was found to be statistically significant with a p-value of less than 0.02. The middle graph compares the difference in the mean number of patients presenting to the ED for paracentesis before, as seen by the red bar, and after the establishment of the FLASP clinic, as seen by the blue bar, a difference which was also found to be statistically significant. The graph also displays the mean number of patient discharges and admissions from the ED with respect to pre- and post-establishment of the clinic. The decrease in the mean number of discharges per day was also found to be statistically significant. The pie chart at the bottom demonstrates the show rate in the FLASP clinic. 90% of patients presented to the FLASP clinic when scheduled, as indicated by the dark blue. Of the 10% who did not show to the clinic, as represented by the red, 50% were due to patients being admitted to the hospital at that time. This study describes the impact of creating a dedicated paracentesis clinic for patients requiring large volume paracentesis in the outpatient setting on ED utilization. Numerous studies have shown the impact on ED utilization when outpatient paracentesis is not available. While most hospitals have the ability to refer their patients to the radiology department to undergo paracentesis as an outpatient, this is not a feasible option at safety net hospitals given the limited resources available and the large volume of patients seen. Given the success of our pilot study, we next plan on introducing thoracentesis and lumbar punctures to the FLASP clinic in anticipation of having a similar, though likely smaller, positive impact. We also believe that future multi-center studies involving other safety net hospitals with increased patient recruitment with propensity score matching between control and experimental groups is necessary to fully establish the findings of our study. A question that one may pose regarding our study may be, outside of the positive impact that was found on decreasing ED utilization, was there any positive impact noted on patients who were transitioned into the clinic? While we are in the process of collecting this data from the patients via a survey, many of the patients have already reported an improved quality of life in that 1, they can schedule their appointments easily and are seen promptly, as opposed to the ED where they end up spending over 8 hours waiting for a paracentesis. 2, they appreciate having a dedicated physician who is an expert at the procedure and is able to perform it quickly and safely, as opposed to in the ED they do not have consistently the same person that is well trained in the procedure. And 3, they feel heard by the staff as we spend time educating them on their diet and fluid intake, as well as their disease process. Another question that one may pose may be, do you believe this outcome is generalizable to other safety net hospitals? My answer would be yes. In fact, another Department of Health Services hospital named Olive View Medical Center had also created a paracentesis clinic and saw a 30% reduction in ED utilization over 1 year, while we saw over a 50% reduction in just a few months. Thus, our future goal is to create a reproducible model of our FOSP clinic that could be implemented at other safety net hospitals by utilizing a mixed method study approach to determine the barriers and facilitators to reduce ED utilization by 80 to 90% for these non-urgent procedures. Thank you for your time, attention, and for this opportunity to present our promising findings.